And welcome to the Dr. Bob Show. We'll be spending most of this show talking about breast cancer. Do you know that both women and men can get breast cancer? Do you know that 1 out of 8 women at some time in their life will get breast cancer? 1 out of 8? We'll be discussing breast cancer. Can it be prevented? What can we do to keep from getting breast cancer? Who's at risk? My guest is Dr. Will Gibson. Dr. Gibson is a board-certified general surgeon who focuses his practice on breast cancer, although he does other parts of general surgery. Hello, I'm Dr. Robert Overholt. I'll be your host for the next 30 minutes. And during the show, we'll be talking about how exercise and laughter and eating properly and wellness in general will help improve your chances of not getting breast cancer and not being 1 out of 8 women. You'll want to stay tuned. It's going to be a great show. We're talking with Dr. Will Gibson, board-certified general surgeon who focuses on the breast, and we'll be learning about breast cancer. How common is it? Can we prevent it? A lot of information. You're going to love the show. Will, welcome to the Dr. Bob Show.
Thanks, Dr. Bob. I'm glad to be here.
How common and how big a problem is breast cancer?
It is a very common and very big problem in our country. To me, it feels like an epidemic sometimes with the constant flow that I see into my office. The statistics, as you alluded to at the beginning, are about 1 in 8 women will be diagnosed with breast cancer at some point in her lifetime. That translates into about 300,000 a year in the United States of an invasive cancer, and then there's another 50,000 a year of what's called non-invasive cancer. That's a lot of women. I like to think about the 1 in 8. Most of us have been in Neyland Stadium at some point or another, and you think about half the people in there are women, about 50,000, and if you look around, 1 in 8 of those will get breast cancer. So even just out of a Saturday afternoon gathering like that, that's a lot of people.
That's a huge amount of people. So are women aware of the frequency of breast cancer? Are they scared of getting breast cancer?
Not all, of course, but I think there has been some improved awareness with different public service messages over the last few years. Most women are pretty diligent about getting mammograms, which I know we're going to talk about in more detail. But what I've found is that even with some awareness, when that diagnosis of breast cancer arrives, it takes a toll, and so that's where I come in and some other physicians like me to help bring them through a difficult time with what's almost always a wonderful outcome.
So how does a person know if they have a risk factor for getting breast cancer?
Well, there are several. Some are more obvious than others, and that's a great question. The most obvious risk factor is being female. Now, as you alluded to before, men can get breast cancer, but only about 1% of all breast cancers that are diagnosed are in men. So the vast majority are in women. So being a woman is the most important risk factor, and then age is a risk factor. The risk of having breast cancer continues to go up as a woman ages.
Is there a certain age that women are more commonly getting that need to pay more attention? Or what age do they start mammography? We'll talk about that in a minute. But what age do women get breast cancer?
It's very uncommon under age 40. Not unheard of, but less common under age 40. And the real focus on detecting breast cancer starts at 40, and then it continues from there, and it doesn't really decline.
So just because you're not 40 doesn't mean you shouldn't be aware that you can get breast cancer. That's an important message.
It is, and if you're under 40, the biggest risk factors would be a strong family history, meaning a close relative like a mother or a sister having had breast cancer in the past, or in rare cases, there can be a known genetic mutation that goes through different families that's a strong risk factor for cancer.
There's a common genetic mutation. What's it called?
Well, the BRCA1 and BRCA2 are close cousins, and I think that's the most common.
Yeah, we call it BRCA1 or BRCA2, and the words almost get that so fast that we say, well, what does that really mean? What does it mean, BRCA1 mutation?
Well, that is a genetic trait that can be passed from either parent to a child, and that gives that person that holds that genetic mutation roughly 70% chance of developing breast cancer in her lifetime, along with risk for some other cancers. So when we detect those genetic mutations, in my world, it's usually meant to address a breast cancer risk, but there are other risks that we address as well.
So if my sister, or if I was a female, my sister or my mama or even grandmama, if they had breast cancer at an early age, what would you advise a 28-year-old lady?
Well, not everyone needs genetic testing without a diagnosis of cancer. What I would advise is be diligent with screening mammograms. It seems like we keep coming back to that topic.
That's so important.
It is so important. Screening mammograms lead to early detection of breast cancer, and early detection leads to good outcomes and lives saved. So, and to answer your question, I would tell that family member to be diligent with screening mammogram either at age 40, beginning at age 40, or in some cases we say 10 years younger than the age of diagnosis of the youngest family member who was diagnosed.
So if somebody in the family had the diagnosis of breast cancer at age 30, the patient that we're talking to in at the office needs to think about it at age 20.
That's a rare case, but that's true.
Genetic counseling, if somebody has breast cancer in one breast, is it more common in the other breast? Do you get, there's a million questions I got.
Well, if a woman develops cancer in one breast, it kind of shows that her body has the wherewithal to make one cancer, which means she is at risk for forming another in her lifetime in the other breast. Now, one breast cancer will not spread to the other breast. If breast cancer spreads, it goes different places, but there is a risk of developing new cancers in the other breast.
So if there is a lady that has breast cancer and surgery removes that breast, do you automatically go to genetic counseling in that patient if they're age 28 or 40, or is there a cutoff?
Under 50, almost, I would say automatic, yes. There's actually been a lot of momentum toward increasing the amount of genetic testing we do over the last 5 years or so. And what we've learned out of testing more women is that more people and more families do carry genetic mutations than we used to think. We used to think that it was only about 1% of breast cancers associated with that, but now it's going up. So the work of the genetic counselors has increased dramatically in the last few years.
Risk factors, we've got age, we've got family history. What other risk factors?
Well, some of the more common risk factors with any health problem, such as smoking, being overweight, and heavy alcohol use, have to be included. They're not exclusive to breast cancer, but they do add to a lot of health risks.
Yeah, so if you smoke, quit it. And if you're overweight, does that increase the incidence of breast cancer?
It does. It does, probably because of the increased amount of circulating estrogen that goes with being overweight can promote breast cancer growth.
Any other common risk factor that comes to mind that you tell patients?
We've covered the ones that I cover with patients most thoroughly.
So if a person comes in and they're worried about breast cancer, what does a breast cancer feel like? When you feel the breast, what is a little breast cancer that's as big as the end of my thumb? What does that feel like?
A marble, and oftentimes.
Smooth marble?
Yeah, pretty smooth.
Gritty?
When feeling it through the skin, that kind of smooths it out. And so I think what you're asking is how does a woman come into an office with a new breast cancer diagnosis? Some of them are because the woman identified this mass herself. And there's always been a lot of encouragement of doing breast self-exams, and that is a healthy thing to do and many tumors are diagnosed that way, but it's important to remember it's not at the expense of doing the mammogram.
So is a mammogram an easy thing to get? Is it a good diagnostic tool? Is it, you say it's really worthwhile getting it?
Yes, all of the above.
That's what we're going to be talking about when we come back. What are the indications of mammogram? It seems to be they change frequently according to different societies. When should you get your mammogram, and how frequent should you get it, and you should get it until when? We'll answer that when we come back. We're talking with Dr. Will Gibson, board-certified general surgeon who focuses on breast and breast cancer, and we're talking about mammography. What is mammography?
Mammography is an X-ray of the breast with the purpose of trying to detect tumors that may be lurking in there that we need to find and remove.
Is the X-ray mammogram accurate in general?
In general, yes. I think we can't expect perfection out of any technology, but in general, we have very good results with mammography in detecting tumors earlier than you can feel them.
What does it look like when you've got a breast cancer and you're doing a mammogram? What does it look like when you're viewing it? Is it something in 3D, or is it something on an X-ray?
Both exist. A traditional mammogram is two-dimensional, taken from two views, but the latest trend in the last few years is something called a tomogram, which is a three-dimensional mammography, and it has become more sensitive in detecting tumors. And you ask what it looks like. The typical description is what's called, this is medical terminology, a spiculated density.
So
that
what's
means
spiculated density?
I'm glad you asked. It means a little solid mass within the breast, and spiculations sounds like spikes, right?
Yeah.
Breast cancers have little spikes sticking off of
Can
them.
you see them?
You can on a mammogram, yes.
Do you have to have the tomography or the 3D, or can you just do it on a, you can see that on a regular?
You can often see them on a regular mammogram, but tomogram does help, and often you can see them smaller or earlier with three-dimensional tomography than you would on a two-dimensional mammogram.
So if the radiologist says there's a suspicious area, we need to get further testing, what is more sophisticated than just the mammogram?
Well, in terms of imaging, the next thing they would do is go to an ultrasound, which is a painless test which uses sound waves to measure changes in density throughout the breast.
So you can do a sound wave test on a breast.
Yes, you can.
Is it bothered by a big breast or a smaller breast or a denser breast? We'll get to a dense breast in a minute. So what is the ultrasound's difficulty and what's its limitation?
Limitation is size to some degree, because the probe is fairly small, about 4 centimeters wide, and so it takes more time and effort and a very keen eye to scan all of the breast tissue.
That's why there are ultrasonographers, people that just really specialize. Are there breast ultrasonographers?
Oh, there are, and they're a talented group of people, and I'm fortunate to work with several of them here in town who are experts in their job, and they make the job of the rest of us better by finding hard to find little tumors.
So, without advertising, name me a couple of groups that have good ultrasonographers for the breast.
Well, my own personal experience comes from Knoxville Comprehensive Breast Center and the Park West Hospital Breast Center, both of which are top-notch.
And isn't that great to know that in little old Knoxville, scruffy, the Wall Street Journal called it a scruffy city.
That's right.
That we've got the best of the best here. And I am so impressed with the subspecialists that we have, and a specialist in ultrasound of the breast. So they're good. Park West has a good one. Knoxville Comprehensive Breast Center is good. So what do they tell you? What can they find on a super duper ultrasound?
Well, they can find little densities within the breast.
Spicules?
Often, yes, but irregular borders and density and shadowing, because sound waves pass through the breast and create shadowing behind it. And this is a clue that really that's something that we need to biopsy, because that's where the real diagnosis comes in.
So how do you biopsy a breast? What do you do? Walk me through that.
Most of them are done with ultrasound guidance, and
Well, what does that mean?
Meaning-
Ultrasound guidance?
meaning the target, the suspicious spot in the breast that we want to biopsy is targeted in real time with the ultrasound. The skin and the breast tissue are injected with numbing medicine to try to minimize pain. It hurts a little bit, but not a lot. And then a needle is passed through the skin into that little suspicious mass while we're looking at it with ultrasound, and it clips out just a tiny bit of the fragment of that suspicious mass and takes it out so that a pathologist can look at it under the microscope, and that's the type of doctor that truly renders the diagnosis of a cancer.
So the pathologist looks under a microscope and says, these cells are abnormal, or they're normal. Go back and tell the patient they don't have breast cancer or that they do have.
That's right.
How important is the pathologist in reading them?
Oh, they're of vital importance
Yeah,
because
they're
they are making the diagnosis at the tissue level.
So how do you tell a patient? How do you tell them they've got cancer? I would say, well, there was something that suspicious showed, and it probably is going to be a cancer. We're going to have to remove it. Or how do you walk toward taking that lump
That's a
out?
great question that many of us spend years in our practice thinking about and trying to perfect. And I can't say that I've done that, but the approach I've taken is that people want the truth, but it's important to be gentle and compassionate while delivering the truth. You have to combine those.
I've got to mention, I Googled your name, Will Gibson, and I looked at the video that you have, and you are such a good teacher and so compassionate, and it's so worthwhile. So to the viewing audience, Google Will Gibson, Premier Surgery, and push on the video and you'll be impressed. So let's get back to, you find that you think that it's a breast cancer, and how do you tell the patient then?
You have to tell them the truth and be compassionate and say exactly what we found, and then you got to have a plan ready. I find that that's very helpful because getting the news without a plan of attack is very disconcerting, very unsettling. But if they come in and say, look, we found a cancer, but I do this all day, every day. I have a lot of experience with this, and I put a lot of time and attention into doing this the very best way that I can, and here's how we're going to approach it for you. Often they leave that appointment in much better shape than they arrived because there's a lot of comfort in knowing that we're going to do something about this.
Is every breast the same, or is every patient and every breast different?
Well, you know the answer to
Yeah,
that
that's
question.
right.
Everyone is different, and we need to tailor our conversation and our approach to the individual needs of that patient.
If you find that little breast cancer lump, and you find out from the pathologist that it's not aggressive, is that great news, or they still got cancer and you got problems?
Both are true. There's a broad variety of breast cancers, some quite aggressive and some not so much. All of them need treatment because even the least aggressive cancers, if left untreated, would probably cause problems in the long term. They would. So we're going to address them all, but we address them appropriately according to that level of aggression, and it's my job to make those distinctions.
Are there different approaches then? Because that's what we're going to be talking about when we come back. Do you simply take out a little lump, or do you have to take out the whole breast, or is it better to get genetic counseling and see if you need to take out both breasts, or depends on your family? A lot of information. A lot has to be deciphered from the brain of Dr. Will Gibson. We'll be back talking about that. We're talking with Dr. Will Gibson, board-certified general surgeon who focuses on breast disease or breast cancer. And we're talking now about once you get the diagnosis, and you've got to be compassionate, and you've got to make sure that the patient is not overly frightened with that. What do you do to take care of that breast cancer? So What's the approach to treating breast cancer in general?
Well, in general, let's talk about the different treatment modalities for breast cancer. Most of these go to surgery first. That's
Surgery
why,
easy or hard?
well, that's in the eye of the beholder. And there are variations.
That was a bad question. For you, you've done so many that it's something that you are well trained in and the patient can feel comfortable.
I hope so. I do think that I have a lot of experience with this. But then the other perspective is it easy or hard for the patient? That's an important question. They all think it's pretty hard. But we get them through it very well, and I think they're satisfied with the results most of the time.
So how do you do you said surgery, what kind of surgery?
Surgery is first-line treatment in about 80% of cases.
So when you do a lumpectomy, what do you do?
So a lot of times these tumors are very small, hidden deep within the breast tissue, diagnosed only by mammogram or ultrasound, as we've talked about already. So we need some type of target, some type of guidance to that tumor. And there are different technologies out there that do that. Those technologies are getting better. The traditional old-fashioned technology is for a radiologist to numb the skin and place a wire through the skin down toward the tumor, into the tumor, and I follow the wire down and take the tissue around it. That's how I find the proper target, when otherwise it's a virtual needle in a haystack for a tumor that can't be seen or felt.
So now you're guiding with X-ray, a wire under a local anesthetic,
Yes.
But the patient is what kind of anesthesia?
When the wire is placed, they're awake and they have local anesthetic. When they come to surgery for me, it's general anesthetic. They are asleep completely and they'll have no pain and no memory of the procedure.
So, which is ultra important to the patient, who's the
is.
important person that we're talking about here. So you've got wire guidance. Is there any improvement in the guidance mechanisms?
There is improvement. There are some implantable seeds of various technologies that can be used now. The benefit of those is they don't have to be done specifically on the day of surgery, as the wire does, because it sticks out of the patient. And then they also allow for a little more choice in where we place the incision. One of the important things we've come to focus on in breast cancer surgery in the last few years is combining successful removal of a tumor with a good cosmetic result. And that means hiding scars to the best of our ability and then reshaping the breast tissue so that it doesn't look concaved. It doesn't look like we removed a big chunk of it.
There's not a big hole in the breast.
Right.
So is that part of your training, is being able to make the breast look like it was before, even though you've taken out a lump?
All of this, that's a great question. All of this has come about since I completed my formal training. So I've added this training during my career. And anybody who's really committed to their career should be committed to learning. And that's what I've done. So I do this with great frequency every day, but it's something I've learned along the way.
So I think every great physician wants to teach and wants to learn every day. I think that's a great statement you just made. It makes goosebumps pop up because I know just by saying that how good you are. Now, let's jump away from surgery, and I'm going to come back to it. What other forms of treatment are there other than guiding, removing the tumor, reshaping the breast, and then seeing the patient back? What other forms of treatment are there? I'm thinking of a couple, like X-ray. Is that a treatment?
Radiation.
Yeah.
So the main treatment modalities for breast cancer would be surgery, chemotherapy, radiation, and something we call endocrine therapy, which is hormone blockers.
So you're telling me that there are different practices, and we use the word multiple disciplinary treatment for breast cancer. And that in a one sentence definition would be what? A multidisciplinary. You got a radiologist, you got a pathologist.
Medical oncologist, surgeon, radiation oncologist, plastic surgeon, genetic counselors.
Wow. So
all of whom contribute
to that one person with that one person. That must make the patient feel a whole lot better.
I think it really does. There's two concepts, two aspects of the multidisciplinary approach. It's best for the patient because they have the benefit of a lot of what I think smart people putting their heads together to formulate a plan that best suits their needs. Then this is more selfishly, from the professional side, it's satisfying to me to work with all of these colleagues, and we know we have confidence when we're all working together and we all agree on the appropriate plan.
That's huge. It's huge for me to learn that multi-doctors figure out the best way for this one patient. Will Gibson, you're a great teacher. Would you come back and do a show with me on what is the multidisciplinary treatment of breast cancer?
I'd be glad to. I could talk about that for a while.
And that's what we'll do when we come back. But that's all the time we have for this show. Remember, you need to be exercising. You need to exercise 5, 6, or 7 days a week. You need to get 7.5 hours of sleep. If you get 7.5 hours of sleep, you'll feel better, you'll laugh more, you'll do better. Eat properly. What you eat is really what you end up being. And most of all, what do we like? It's that laughter in your life. Laugh a lot and you'll stay healthy.